how will we approach a patient who is unconscious? I am sure all of you must have seen an unconscious patient at some point of the other in your student career till now. Have you ever seen an unconscious patient? Have you ever managed an unconscious patient? Leg raise. Okay, right. So what is consciousness? How do you define consciousness? What is consciousness? All of you are conscious. All of you are sitting. What is consciousness? What is the difference between a person who is awake and a person who is conscious? So a person who is awake will just have his eyes open, will have his reflexes intact, but he will not be able to respond. Respond to what? Respond to any external stimuli. It can be mechanical, it can be emotional, it can be painful. There is no reaction if a person is not conscious. And exactly that is what is the definition of consciousness. That is, when a person is aware of what is around him and can respond appropriately to the external or internal stimuli. The stimulus can arise from the external world or inside the person's own self also. Okay? And what is important? What is important for your consciousness to be intact? What is required? So, consciousness, as we know it, is primarily a function of your central nervous system. It depends on the functional as well as the physiological integrity of the central nervous system. Can any one of you tell me what are the components of the central nervous system? The components of the central nervous system. Sit down, sit down. No need to stand up. Sit down. Right. Brain. Anyone else? Spinal cord. Right. Anything else? Anything else? What comes out of the spinal cord? The peripheral nerves. Right. So the central nervous system mainly consists of the brain, the spinal cord, and the peripheral nerves. Right. So the functional and the anatomical integrity of all three of these is important for your consciousness to be intact. Okay. Now, like I was telling you, all of you are conscious, right? All of you are sitting. Some of you might be daydreaming. Some of you might be mentally asleep. But by and large, I assume all of you to be conscious. So what is the normal level of consciousness? When a person, like I said, is not only awake, but is also alert and is cooperative. What is the meaning of cooperative? That the patient is responding. Like if I ask you something, you are answering. If you are feeling cold, you can ask the person to decrease the AC. If you are feeling hot, you can ask the person to lower the temperature. So you are responding. So a patient is not only awake, he is also alert and he is cooperative. He is responding to external and internal stimuli. That is the normal level of consciousness. Now, what do you think are the altered levels of consciousness when a patient is not conscious? So, primarily we have three types of altered consciousness. One is obtundation, one is stupor, and the last one is coma. Obtundation and stupor is not what we are going to discuss today. It is an altered level of consciousness, however, where the patient is not completely comatose or not completely unresponsive or not completely unconscious. So it is not normal, but a patient, he is awake, but probably he is not responding appropriately to external stimuli. That is what we know as obtundation, or if that gets more severe, then we can call it as stupor. Can you give me an example? Very common example, especially medical students, where you are obtunded or in a stuporous state. Huh? Viva. No, not Viva. Viva, you need to be awake, right? Viva, you need to be alert. But what about alcohol? Right? So we just had Holi a few days back. I'm sure a lot of you must have had the good fortune of tasting cannabis. So that is ganja. So you are awake. You are probably awake, but then you are not responding appropriately. So alcohol is one of the most important causes of mental obtundation. Or if you drink too much, then probably you will land up in a stuporous state, right? And if you drink even more, then probably you will become completely unconscious, and that is the topic for today's class. So don't think I'm encouraging you to pursue alcohol or narcotics, but just an example. Okay. So what is the definition of coma or unconsciousness? Same like we just discussed. When a patient is not awake, just remember two things. This is something that can be asked as a short note for a 5-mark question. A patient who is not awake, number one, a patient who is not responding to external or internal stimuli. These are the two main points that you need to remember, and these are the two main points that you need to write in your exam. Apart from the other sleep-wake cycle and everything, that is a part of the definition that you need to mug up. But remember the two important things is awake and is responding to stimuli, right? And clinically, so there is a parameter, there is a scoring system where we can grade the severity of unconsciousness. That, as we will discuss later, is something that we measure by a Glasgow coma scale, or very commonly, or very in short, referred to as GCS. So a GCS of less than 8, if it persists for more than 6 hours, you can call the patient to be in a state of coma. A GCS of less than 8 will probably render a patient unconscious, but if that persists for a period of 6 hours, then you will call the patient to be in coma. Okay. So, like we discussed, the integrity and the integrity of the central nervous system is paramount, is very important for the normal consciousness to be intact. And amongst the parts of the central nervous system, the two very important parts which play a role in your consciousness is, number one, the cerebral cortex, and number two, the reticular activating system, right? Now, can any one of you, you've done your anatomy classes in your first prof, I believe, right? You've heard of Brodmann's areas. Which is your motor area? Precentral gyrus, right? What is the Brodmann area? 4. Brodmann's area 4. And which is your sensory area? 312, that is the postcentral gyrus. Very good. So cerebral cortex, amongst the parts of the central nervous system, cerebral cortex and your reticular activating system is the most important thing for maintaining your normal consciousness. Can any one of you tell me what the reticular activating system consists of? Or what is it used for? Why is it important? Okay, wakefulness. So reticular activating system, remember, is very important for two things. One is your memory. When you see things, you remember the part of the brain which does not work in your vivas. And it is the second part is your emotional construct. If somebody of you is feeling sad, somebody of you is feeling anxious, okay, somebody of you may be feeling depressed, someone may be feeling very happy, very elated. your emotional construct depends on your, okay, so your emotional construct and your memory. These are the two most important things that are determined by your reticular activating system and hence forms a part of your conscious behavior, right? And the other, like we discussed, is the cerebral cortex. Okay. So, what are the causes of unconsciousness? Apart from alcohol, like we just discussed, what are the causes? Or like I told you, if you have ever seen an unconscious patient, just remember, most of you would have seen an unconscious patient at some point in your life, maybe elders, maybe juniors, maybe children. Just try and remember why they became unconscious. Probably, they met with a road traffic accident, probably because of old age, probably because of alcohol, probably because of stroke, very common paralysis, stroke. Probably, they had some sort of an electrolyte imbalance, sodium falls, potassium falls, very common. Patients, admitted in the ICU. Somebody may have landed up in sepsis. Somebody may have suffered a heart attack or a myocardial infarction. These are all the causes of unconsciousness. So, like I have mentioned, these are of course some of the most important or the most commonly encountered causes. However, in causes of unconsciousness, you can write pages after pages. There are lots and lots and lots and lots of causes of unconsciousness, these being some of the common ones. Okay. And even amongst these, the vascular cause, strokes and road traffic accidents resulting in traumatic brain injury. Bike eshe mere gelo, truck eshe mere dilo, bomb blast hoye gelo, Q eshe mathay mere dilo. Traumatic brain injury and vascular causes are the most, even amongst these, are the most important causes of unconsciousness that you will encounter on a daily basis. Okay. Right. So, like we discussed, clinical features of unconsciousness, just imagine a lifeless body. Just imagine a patient who's dead. That is what is unconsciousness. You call that patient, he will not respond. You, test his reflexes, may be present, may be absent. You talk to the patient, he will not respond. The eyes will not open. You pick up a patient's hand, you drop it, it will probably fall like a log of wood. So these are all the clinical features of unconsciousness. However, the patient is not clinically dead, right? Because if the patient is clinically dead, then he'll not be unconscious. Unconsciousness is a state where the patient is not clinically dead, but is appearing to be so, right? So we will be discussing in detail, but then these are some of the common clinical features that you will see in a unconscious patient, right? So coming to the management, how do you manage? Now after all of you become doctors, you will be starting your internship. How do you manage a patient who's unconscious? So I have outlined some of the basics, some of the basic points regarding management. We'll be discussing about each one of them in detail. But first of all, don't try to be heroic in your efforts. Call for help. Call your seniors, call your colleagues, call the people who are there in the emergency or wherever you might encounter an unconscious patient. Call for help. That should be your first step, in addition to the other points that I have mentioned. What are those? So first is, after you call for help, you activate emergency services. In India, the number is 108. Like for police we dial 100. For any medical emergency, be it a life-threatening emergency, be it a suspected drug overdose, be it for your ambulance, for any medical related emergency, the government of India has prescribed this number 108. Like you have 911 in the United States of America, in India it is 108. So you activate. If you are outside the hospital, you activate this number. You call for help. You seek the response from the nearest tertiary center. And in the meantime, you also start to resuscitate the patient. How will you do that? You provide basic life support. If you are working inside the hospital, you give advanced cardiac life support. If the patient has been rendered unconscious as a result of trauma, you do this primary and secondary survey, and most importantly, you try and find out what has made the patient unconscious and you manage it. Basic life support and advanced cardiac life support is something that is very, very important. All of you must know as doctors, not only for your exams, but also in your practical careers ahead. Basic life support and advanced cardiac life support is something that is a must. You will not pass your examination if you cannot say what BLS is, and if you cannot demonstrate BLS on a mummy. We ask you to demonstrate BLS on a mannequin. What comes to your mind when I say BLS? ABC, right? Very commonly done in airports, bus stations, you must have seen in trains. CPR, right? Chest compressions. All of you must know how to perform chest compressions, how to give rescue breath. That is life-saving. Remember, whenever, you might have heard of announcements inside the aircraft, if a person is not feeling well, if a person has become unconscious, the air hostesses or the air stewardess, he or she will announce that is there a doctor on board. And if you see the person who's unconscious, start your basic life support. Start to give chest compressions. Give rescue breaths, right? Okay, so if the patient has come to you unconscious because of trauma, then we proceed for primary and secondary survey. That is the internationally laid down guideline that we perform in cases of unconsciousness due to trauma. Now, like you said, we have two ABCs. One ABC is performed for the primary survey, and one ABC is performed in the management, that is airway, breathing and circulation. We will be discussing both of them. So starting with A, that is to manage your or to observe your airway. That is the most important thing. Remember, for a person to be alive, you need three things, right? You basically need three things. You need oxygen, right? You need a pump that will pump the oxygen, and you need blood. Oxygen, this airway will take care of the oxygen part. Breathing, the pump, what delivers the oxygen throughout your body. We'll be discussing that later. And C is your circulation, which stands for blood. We just need these three things to basically keep you alive. Okay, so starting with your airway. Now, these are certain maneuvers, which you perform to ensure that the airway is open. Now, suppose if a person is unconscious, what happens is the tongue falls back. Or if the person has met with an accident, there might be mud, there might be debris, there might be a lot of, foreign bodies inside your mouth that might be obstructing the passage of air. There might be dust. If the patient has suffered a bomb blast injury, if the patient has suffered a burn injury, there might be smoke, there might be soot inside your nostrils. inside your nasal cavities. So the first point that all of you should do is to clear your airway, which includes the mouth as well as the nostrils. And these are some of the maneuvers. This head tilt and your chin lift and jaw thrust, these are some of the maneuvers. You probably don't need to know what it is now, or you don't need to demonstrate it now, but just remember the names. These three names are very important and very commonly practiced. Everyone does it. Chin lift, head tilt, and jaw thrust. Only if you suspect that the patient has an intact cervical spine. If the patient has suffered some kind of a trauma, we always take it for granted that the patient may be having a cervical spine injury. The last part, jaw thrust, is not performed if a patient is suspected to have a cervical spine injury. Why? Because you might be displacing the cervical spine. That might render the patient paralyzed for life. So, head tilt, chin lift, fine. Jaw thrust, you will only perform once you have ruled out a cervical spine injury. And in all cases of road traffic or in all cases of unconsciousness because of trauma, you always take it for granted that the patient has a cervical spine injury. And it is for that reason that we must always stabilize the cervical spine by any splint that you can get. We usually use a cervical collar, a Philadelphia collar, but even if you don't have a Philadelphia collar, you have to support the patient's cervical spine with your hands, with both of your hands. Something that is called as a manual stabilization. You actually have to support it like this, you know. You have to hold the patient's cervical spine, you know, and so such that the cervical spine and the ears are in one line. That is how you need to transport. You actually have to hold it. Somebody has to hold while the patient is being brought inside, you know, in an ambulance or, you know, wherever. You must have seen some ward boy or somebody, anybody who's a helper, one person will always hold the head so that there is minimal movement in the cervical spine. If the patient is suspected to have a cervical spine injury and if the cervical spine is moving up and down, then it will only worsen the situation. A person who was just unconscious now will become unconscious as well as paralyzed. So you don't want that, right? Okay. So the next part is to ensure that the patient is breathing. So how will you assess breathing? A patient who's unconscious, right? How will you assess for breathing? So you will stoop down to the level of the patient and you will see if the chest is rising or not. If the patient is spontaneously breathing or not. Or if only one side of the chest is rising. Both sides should rise and fall, right? Both sides should rise and fall. If only one side is rising, you might suspect that the opposite side may be damaged. One of the very common causes is pneumothorax, very common cause. Just yesterday, I had a patient, a day before yesterday, you know, in Calcutta, I had a patient with a traumatic pneumothorax. The patient came in with a saturation of around 80%, extremely tachypneic, extremely short of breath, and the patient came to our ICU. I inserted a needle in the second intercostal space, followed by a chest drain placement. Just day before yesterday, we had a patient of a traumatic pneumothorax, very common, very, very common. Okay, so you must ensure that the patient is breathing. If the patient is breathing by himself, fine, well and good. You try to assist the patient. You can give supplemental oxygen. Or if you feel that the patient is not taking breaths adequately, the respiratory pattern is irregular, then you need to intervene. You probably need to intubate. Tracheal intubation, you need to put in an endotracheal tube. You might have to put the patient on a ventilator, right? So assessment of breathing is your second part. So A is for airway. You clear the airway. B is for breathing. You assess whether the patient is breathing properly or not. and C is for your circulation. So we have covered your oxygen, we have covered the pump, and now we are talking of blood. So how will you ensure whether the patient has a normal circulation or not? What do you do? What is the first thing that you do? To see whether the patient is right. You check the patient's pulse, right? You check the patient's pulse to see whether the patient is having an adequate circulation or not. So that is the first thing that you should do. You check the patient's pulse. What are the other things? What are the other things? Right, you look for any obvious source of bleeding. Very common, very common. When I was in RG trauma, every day, every single day we used to have patients coming in with stab injuries, with an open chest, open mouth, open brain, a limb missing, hand missing. Okay, patient is coming to the emergency, catching hold of his own hand. The ear has been torn off, the ear has been brought in a bag, the fingers have been cut off, the fingers have been brought. 3 fingers have been cut off, the patient has brought only 2 fingers. Sir, rasta aste aste ekta angul pore geche. Very common, very common. So if there is any external visible source of bleeding, try and control it. How will you try and control it? Put a tourniquet. Put a tourniquet so that the patient does not bleed more. And check for all the peripheral pulses. Which are the 2 most important pulses that you will look for? Radial is not always palpable. What if the hand is only missing? Very good. Carotid. Carotid. This is the main pulse that you will see. This is the main pulse that will determine whether a patient is awake or, alive or dead. Radial, tibial, popliteal, even femoral may be absent. But if this is gone, your patient is also gone, most probably. So you tell the patient party, Jaan nahi, we will wait for 30 minutes, we will confirm death, but patient probably cannot be revived. Carotid, make a habit whenever you see an unconscious patient. You are in a railway station, somebody falls. Nowadays, it's very common, sudden cardiac death. Celebrities working out in the gym suddenly drop dead. Recently, I happened to visit Prayagraj for Kumbh Mela. Lot of patients, lot of people walking in front of me suddenly fell down. Very common, dehydration. Whenever you see a patient who has fallen unconscious, always and always make it a practice, make it a habit of checking the carotids to first see whether the patient is alive or not. If the carotids are absent, don't waste any time. You ask somebody else, you call up 108, you call up for the ambulance, you start giving CPR. You start giving chest compressions. That might be the difference between life and death. So in anesthesia, we usually are always dealing with emergencies. Always anesthesia means emergency, either inside the OT or in the ICU. These are the 2 places where the anesthetists work. These are the 2 places that are under our control. One is the intensive care unit and the other is the OT. Always and always you have to deal with emergencies. Any emergency, anywhere in the hospital, you, the surgeon and the medicine on call, these 3 people will always be called. Okay. So, whenever you see a patient who is unconscious, always and always, first of all, check the pulse. Even before you clear the airways or do anything else, first check the pulse. And the best pulse that you can, and the most easily felt pulse is the carotid. Right? Okay. So, even like we all know, if the patient is not having an active circulation, the patient will have cold and clammy extremities. The patient may have a less urine output. The patient may become fully cyanosed. You know what cyanosis is? Cyanosis, right. So, if you see a patient who is lying unconscious, the lips have turned blue. The hands, they are stone cold. Probably the patient has a compromised circulation, right? Okay. So A is for airway, B is for breathing, C is for circulation. Then we come to D, which is your disability. And in disability, like we mentioned, how do you quantify unconsciousness or how do you grade unconsciousness? So there are mainly two scoring systems. One is your Glasgow Coma Scale, and the second is your, which is most commonly done, I mean can be easily done, is the AVPU scale. More than the AVPU scale, Glasgow Coma Scale is something that all of you should know, will be asked in your Viva, will be asked as a short question, may be asked as a long question also, we will be coming to that. So these are the two most commonly performed scoring systems that we have in our kitty to quantify or to grade the severity of unconsciousness. Remember, a GCS of less than 8. What is the maximum GCS? 15. What is the minimum? No. 3. Very good. So this is again an MCQ, okay? In your NEET PG, you might be getting an MCQ. What is the minimum score of GCS? And most of you, the reflex that comes is 1 or 0. In GCS, the minimum score is 3. The lowest GCS, a person who is brain dead. So we have a lot of patients. When I was in RG we used to have a lot of brain dead patients who were harvested for their organs, for organ donation. Kidneys, liver, lungs, especially after the COVID pandemic. So a person who is brain dead, a person is alive, his heart is pumping, but the brainstem reflexes are absent. That person is brain dead. So we used to tell the patient party, the relatives of the patient, that the patient is brain dead. And if we have a patient who is in need for an organ, most commonly a kidney, we used to always ask that, would you like to volunteer for your patient to donate an organ? So many times we used to harvest organs. Organ harvesting would be done. So in brain dead patients, you have a GCS of 3, not 0, not 1. GCS will always, and the lowest GCS possible is 3. Okay. We'll be seeing what the GCS is. And less than 8, like we said, the definition of unconsciousness was a GCS of less than 8. Coma is GCS of less than 8 for more than 6 hours. But unconsciousness is usually, most commonly it is a GCS of less than 8. And in those cases, we always have to intubate the patient. We take it for granted that the patient who is having a GCS of less than 8 will not be able to protect the airways. What do you mean by protect the airways? The patient may aspirate. Cough reflex is absent, gag reflex is absent. The patient may aspirate. The oral or the nasal secretions can go inside the lungs, and the patient can land up in something that is called as aspiration pneumonitis. So in order to protect the airways, we have to intubate and put the patient on a ventilator. Okay. Right. So after A, B, C and D, we come to E, which is exposure. And exposure quite literally means exposing the patients. A patient who is unconscious may have a lot of hidden injuries. A patient may have a blunt trauma abdomen, or a patient may have a pelvis fracture, or a patient may have a urethral injury. In cases of rape, in cases of in medical legal cases, a patient may have a ruptured perineum. You need to undress the patient, remove all the clothes and examine all the injuries. Any injury that might be present on the front, on the perineum, on the back, all over the body. But that should always be done, number one, in the presence of a witness, and number two, it should always be followed by recovering the patient. You recover the patient with a blanket or with a cloth or whatever it is to prevent hypothermia. After exposing the patient, okay, you document all the injuries and you write all the injuries and you leave the patient like that. The patient will die. Okay. So even if the patient was alive, because the patient will lose heat, the patient will die of hypothermia. Very commonly, very, very commonly done in road traffic accidents, in sexual assault. So you have to expose the patient. E is for exposure. Remove all the clothes. Every piece of clothing, every piece of jewelry has to be removed and you examine from head to toe. Okay? And after you have done it, you recover the patient. Right. So these were the parts of the primary survey. This, in short, is your Glasgow Coma scale. The 3 parameters that are used is, number 1 is eye opening, number 2 is verbal response, and number 3 is motor response. And if you see, the highest score for eye opening is 4, the highest score for verbal response is 5, and the highest score for your motor response is 6. But the lowest score in all 3 parameters is 1. So even if the patient has got an eye opening of 1, verbal response of 1 and motor response of 1, means that the patient has a total GCS of 3. Okay. Now, after you have done your primary survey, now you come to the secondary survey. And in secondary survey, first of all, like we all do in our clinics, you start with the history. This is a very simple mnemonic. You know, you will not have the time to get a detailed history. The patient himself is unconscious, so the patient will not be able to tell you anything. So usually in such cases, you have to obtain the history from whoever has brought the patient, or you have to, obtain the history from circumstantial evidence. Somebody who has seen the patient become unconscious, or somebody who was there, while the patient was unconscious. So you have to obtain a very quick history. These are the points that you must cover in your history, very commonly done by all of us. Okay. And secondly, after you have done the history, you perform a head-to-toe examination. I mentioned, after you have exposed the patient, all this is happening simultaneously. This is not like one after the another. While you are doing your primary survey, you will have somebody to expose the patient. While the patient is exposed, you take the blood, you take the samples, you perform an ultrasound, you get an X-ray done, and you also examine from head to toe. Like I told you, you have to examine very thoroughly, even the eyes, behind your ears, inside your nose, nostrils, the external genitalia, the back, abdomen. All parts should be examined thoroughly to look for any hidden or any latent injuries. Okay. Most important is your spine, the cervical spine, right? Most is your cervical spine, your chest. You have to auscultate. If you see breath sounds in pneumothorax, you will not get breath sounds on one side, right? Or if you have an hemothorax, or if you have a flail chest, you will not get breath sounds on that side, right? So perform a thorough examination, a thorough systemic examination, a head-to-toe assessment, right? And you have to document. You have to document each and every injury, not just for yourselves, for also medico-legal purposes. For example, the patient has come as a result of road traffic accident. The patient has come as a result of intoxication. The patient has, probably taken some illicit or some illegal drugs. The patient probably has injected himself with something. The patient has probably tried to commit suicide, has drank kerosene, or has drank, some insecticide. All these are medico-legal cases. We have to work very closely with the police. A representative of the police will always be present while you are doing all this, and you have to document. Something that you have not documented, the police will not record. So your documentation is paramount. Your documentation is very important to validate that injury. Suppose, after that, in the course of the investigation, if you ever have to go to the court, if you ever have to testify in court, then you can always say that yes, this was the patient who had come, these are the injuries that I had got, and I have mentioned or I have documented each and every one of those injuries. You will have to sign your name, give your registration number, give your stamp. That is a legal document that will be verified with the police, right? So these are very important. You have to perform a thorough examination and you have to document. You cannot perform a thorough examination and once you have documented, the document has gone and then you find out something, oh ho, patient er to ekta scalp hematoma chilo, eta to lekhai holo na, ki korbo? Very commonly done, okay, very, very common mistake. So, not only will you examine, you will also ask one of your colleagues or if you have a senior to verify your findings. And only after that will you document, because it is very common. We are all working, you can miss an injury, and that injury might be very important from the patient's from the perspective of the patient's prognosis. So you must always, whatever injuries you document, you always need to get it verified by the police. Police is the final thing, but first of all, you doubly verify it yourself or you ask one of your seniors or one of your colleagues to help you out, right? Okay. So, like I said, all this is going on simultaneously. So once you have done the primary survey, you are doing the secondary survey and something. In the meantime, you also ask somebody to obtain the blood samples because you need to send the routine investigations, right? You may need, to send the patient to a higher setup. Suppose the hospital that you are working in does not have the requisite facilities. Suppose very commonly, very, very common, a patient comes with a myocardial infarction. Patient has suffered a heart attack. The patient comes to you in your emergency, but your hospital does not have a cath lab. Suppose the patient needs to have a stent that needs to be put in on an emergency basis. But your hospital does not have the requisite facilities. So you need to refer that patient as early as possible to a center or to a hospital that has these facilities, right? So you must make the arrangements simultaneously. You don't have a lot of time. In any case, whenever a patient is unconscious, always remember it is a medical emergency. Try not to waste time. Try not to waste time, doing or performing unnecessary procedures or unnecessary, actions. Time is very important. Time is, you've heard of something called as the golden hour. Golden hour. So anything, any cause of unconsciousness, the first hour is very important. That can be the difference between your life and death. Okay. So while you are doing the primary and the secondary survey, you tell somebody to obtain your blood samples. You send the patient for an X-ray. You get the get a CT scan done. Suppose if the patient you are suspecting has had a head injury, you get a CT scan done. Suppose if you are suspecting that the patient has suffered a heart attack, you get we have to do it. You will also be learning it. So you perform a bedside echocardiography. You get a chest X-ray done. So all this has to be done simultaneously. Very commonly missed, you have to immunize the patient. Suppose if the patient is unconscious because of a road traffic accident, you must always give a tetanus shot to the patient, right? Or suppose, if the patient is a suspected case of poisoning, you have to give the antidote. Very commonly, very common thing that we used to get in our, when I was working in the ICUs was snake bite. Snake bite was very common and the person would come with the snake. So, while you are doing the primary and the secondary survey, you ask the lab to give your anti-snake venom and you start that. You have to give the antidote. Suppose if the patient has been brought in by, a young girl, 14-15-year-old girl has been brought in by the village members, je বাড়িতে স্বামীর সাথে ঝগড়া করে এই pesticide টা হচ্ছে খেয়ে নিয়েছে, and they have brought the pesticide bottle. You see that this is an this is an OP, this is an organophosphorus. So you have to start with, what is the antidote? What is the antidote for organophosphate poisoning? Atropine and pralidoxin. Very good. So You have procholinergic agents. So you have to, give the antidote. Suppose if you have a patient with a suspected opioid poisoning, what is the antidote? Naloxone. Naloxone, right? So you must always know what is to be done. You must always know, what I have to do if I get such and such patient. Right? So the algorithms should be there, the protocols should be there very clearly in your mind. Right. Okay. So the next two slides are something that we usually perform to see if the patient is brain dead or not. Now, a lot of times, while you are doing all this, you might get a suspicion that the patient might be just clinically alive. The patient might be brain dead. Now, once that suspicion comes, you must always perform these two tests. These are the commonest tests and very, rapidly done. It does not require any huge hi-fi equipment. It can be done at the bedside. Just takes about 30 seconds. Perform these two tests. One is your oculocephalic reflex. One is your vestibulo-ocular reflex. You must have read about these in your physiology classes. These two are your commonly performed brainstem reflex tests. If these two are absent, what is the sensitivity of these two tests? You know what sensitivity and specificity is? In community medicine, you must have, true positives and true negatives. Okay, right. So the sensitivity of these tests is almost close to 100%. It's almost 99%. So if the patient has these two tests, if these two reflex tests are absent, most likely the patient is brain dead. But you cannot confirm it. There are other gold standards, but most likely you have to suspect that the patient may be brain dead. So one is your oculocephalic reflex, which is also called as the, what is it called as? It is called as the doll's eye reflex. Doll's eye reflex. Have you ever, all of you must have had, a doll at some point of, or the other in your lives. What is the, what does a doll's eyes do? A doll's eyes don't move. If you are moving the head from one side to another, the eyes will also move towards the direction that you are moving the head, because that is a lifeless object. Now you try it on your friends after you go back to the hostel. You try to move your friend's head from one side to another. You will always see that the pupils are always fixed in midline. That is a normal reflex, because we always need to fix our gaze. Even if our head is moving, the pupils will always be fixed on the gaze, which is not, she's trying it out. See, the commonest, the best way to elicit this response is if somebody is asleep. Do it while somebody is sleeping. Because if somebody is awake, then automatically that patient will look at something, right? Do it while somebody is sleeping. Just try to move the head, open the eyes. You will still see that the pupils always stay in midline. Something that is absent in a patient who is brain dead. You move the patient, the eyes will also move like this. There will be no motion, there will be no midline fixation in the pupils. This is something that is called as the oculocephalic reflex. The second is the vestibulo-ocular reflex, less commonly performed, but yes, also performed, is when you push cold and warm water consecutively. Right. So the mnemonic is cows, okay? Cold opposite, warm same. So you push in cold water and you look for nystagmus. You understand what nystagmus is? Right. You observe for nystagmus in the eyes. So once you are pushing in cold water or warm water, what that water does is it irritates the vestibular apparatus, the labyrinth inside your inner ear, and that will cause as the nystagmus. So once you are giving in cold water, you will have a nystagmus towards the opposite side. If you are giving it in the left ear, you will have the nystagmus towards the right, and vice versa. And Once you are giving warm water or hot water, you will observe the nystagmus on the same side. Okay, so that is something that is called as the vestibulo-ocular reflex. Just know the name, know what the reflex is. This is less commonly asked, but oculocephalic or doll's eye reflex is something that you will be asked in your viva, and that you will be asked to demonstrate also, because it is a very simple test to perform. Okay. Right. So, like I said, while you are doing your primary and secondary survey, you will also obtain certain investigations. Now, investigations always need to be directed towards the cause. If a patient comes to you, with a suspected myocardial infarction, the patient's relatives say that the patient has been hypertensive, diabetic for a long time, the patient was taking, statins at home, the patient would often complain of angina. So you suspect a myocardial infarction. So in those patients, instead of getting a head CT done first, perform an echocardiography. Right? Similarly, if you see a person who was riding a bike, who has crashed, and whose helmet has, has fallen somewhere else, the patient is coming with a huge bruise on his forehead, with blood coming out. So first of all, you perform a head CT, an NCCT head, instead of doing the other investigations. So investigations should always be directed towards the cause of the unconsciousness. Suppose if the patient has come in with a toxin ingestion, like I said, the patient has come after a suicidal attempt, the patient has tried to drink a pesticide. The pesticide bottle is there. First get a toxicology screen. Right? First get a toxicology screen before doing anything else. Suppose if the patient has come as a result of snake bite, right? First get a blood to check for serum levels of snake venom, okay? To check for hemolysis, right? And so your investigations should always be directed towards the cause. These are some of the investigations that I have listed. However, you have to perform the ones first which you are suspecting. Okay, right? So relevant investigations and relevant imaging. A patient who has come with a chest injury, with a chest trauma, don't waste your time getting a CT scan done. First get a chest x-ray. A patient who was probably running on the treadmill, has suddenly collapsed. First get an ECG. Okay, so investigations always need to be directed towards the cause. Right. Now coming to the second ABC, which is the management. Again, airway, breathing and circulation. The first was in primary survey, where we looked for the problems in the airway, breathing and circulation, and now we are trying to manage the problems in the airway, breathing and circulation. So we will again start with the airway, see if the patient is breathing or not, see whether the patient is spontaneously breathing or not. If not, we have to put the patient on a assisted device of ventilation. Can be invasive, can be tracheal intubation, mechanical ventilation, can be anything else. You may need to put in an airway. You have seen any airway? Oropharyngeal, nasopharyngeal airways, you have not seen. Okay, probably you will see it in your clinics. So you need to put in an airway. You need to, make a channel, give IV fluids to ensure that the blood volume stays intact. If the patient is bleeding, you need to put a tourniquet. You need to arrange for blood. You may need to transfuse blood. Okay. And so the sequence that we will follow is airway, breathing and circulation. You have to manage the airway. You know what the problem is. Now you have to manage it by giving supplemental oxygen, by intubating the patient, ventilating the patient if required. You may have to give, CPR to ensure circulation. You may need to give blood. You may need to give IV fluids, blood products. Okay. You may need to give medicines to increase the blood pressure. Suppose, patient has come in with shock. Patient has suffered a road traffic accident. What is the normal blood volume of a human body? Approximate? 5 liters? 5 liters? Okay. Patient has suffered a bomb blast injury. Half of the abdomen is gone. The patient has lost 2 liters of blood in half an hour. So, before doing anything else, secure an IV line, transfuse blood. transfuse blood. Give CPR if required, transfuse blood. And you have to also probably give medicines to increase the blood pressure. The patient has landed up in shock. You try to measure the BP, you cannot see, you cannot measure the BP. The BP is unrecordable. Normal BP is 120 by 80. In a patient who has come in with shock, suppose you are getting a systolic BP of 70. 70 by query, question mark. Diastolic is not measurable only. So, along with IV fluids, along with blood, you have to give fluid, you have to give certain medicines to increase your blood pressure. Can somebody tell me of some medicines that you use to increase the BP? Dobutamine is one. Dobutamine is used in cardiogenic shock. Okay. Epinephrine, very good. What is the other name for epinephrine? Adrenaline. What is the sister or the brother of adrenaline? Noradrenaline. Okay, so these are the commonly used vasopressors or medicines that are used to increase your blood pressure. So you may need to give antibiotics. Suppose if the patient has come in with a suspected septic shock, a patient who was probably suffering from pneumonia for a long period of time has suddenly collapsed. You send the patient's blood investigations, you get a total leukocyte count of around 30,000. So you suspect that the patient might be in a state of septic shock. You need to give antibiotics. You need to probably, a patient who is not breathing, a patient who is not conscious, you may need to put in a Ryle's tube so that the patient does not aspirate. Suppose if the patient is, if he has had a perineal injury, suppose if the patient has, or rather any trauma, the patient will not be able to go up to the bathroom and evacuate himself. You need to put in a Foley's catheter. So these are some of the measures that you have to do simultaneously while managing a patient who is unconscious. Okay. Right. So like I was telling all of you, it's probably too small. The algorithm is, I'll just tell you the main parts. In any case, you will be having a class on basic life support later. So in any patient who is unconscious, like I had told you in the beginning, basic life support is something that all of you must know. This algorithm you have to write in your answer sheets. This algorithm you have to memorize and you have to probably tell in your vivas. Okay. Just to give you the salient features, you will have a separate class on basic life support. If you see a patient who is unconscious, check for breathing, check for your pulse, check for your breathing, and if both of the breathing and the pulse is absent, you start with chest compressions. Chest compressions should be done in a ratio of 30:2. 30:2 is the magic number that all of you must remember. What is 30? What is 2? Right. So you have to pump the chest for 30 times and then give 2 rescue breaths. Give 2 breaths after every 30 chest compressions. Once you are giving CPR, you have to count 1, 2, 3, 4. You have to pump it 30 times, and after 30 compressions, you have to give 2 breaths to the patient. You will have a separate class on your basic life support, but these are the important points. Look for breathing, look for your carotid pulse. Breathing and carotid pulse should be assessed in 10 seconds. That is it. Not more than that. You must not, waste time, 1 minute, 2 minutes checking the pulse, checking the breathing and everything else. Breathing and pulse should be checked in 10 seconds. If both of them are absent, start your chest compressions in a ratio of 30:2. Right. And you continue CPR till your emergency team arrives, or you have transported the patient to the hospital. And once you have transported the patient to the hospital, what do you do? In addition to this chest compression and rescue breaths, what is the other thing that you do? Very commonly done. Right, shock. So that is something that is called as a defibrillation or a cardioversion. So that is a part of your ACLS. We have an algorithm for that too. But for BLS, at least tell 3 things, that will help you to pass. Even if you don't remember anything else, if somebody asks you what is BLS, what do you have to do? You have to first check for pulse, you have to check for breathing in 10 seconds. If both of them are absent, you start with chest compressions in a ratio of 30:2. Okay. Now this is this is the algorithm. These are all standard circulation journal algorithms, all published by the American Heart Association, that is followed worldwide. Okay. So you get a patient with a suspected opioid poisoning, somebody who has taken opioid drugs either suicidally or homicidally. You get a patient with suspected opioid poisoning. The first thing that you do is to administer the antidote, which is naloxone, in addition to performing your CPR, right? And this is your advanced cardiac life support. What you do once the patient has come to the hospital. So in addition to your chest compression and breaths in 30:2, you also assess for the patient's rhythm, the patient's ECG. If the patient has got a rhythm where you feel can be revived with an electric shock, right, which what we called as a shockable rhythm, then you deliver an electric shock. What is the amount of energy that you deliver is 200 joule. Always remember, we deliver biphasic shocks of 200 joules. That is something that is very important that you will be asked. In advanced cardiac life support, we have to defibrillate with 200 joules of biphasic current. In addition to your chest compressions, there is a small little table that is there. This is the table. In addition to your IV adrenaline and on all those things, you have to give a shock if you suspect that the patient has got a shockable rhythm. Okay. Non-shockable rhythms are your pulseless electrical activity and asystole, where you have a flat line. But if you have a shockable rhythm, which is a VT, ventricular tachycardia or a ventricular fibrillation, you give a shock. The shock is 200 joules of biphasic current, in addition to continuing your CPR and your rescue breaths in a ratio of 30:2. So, unconscious patient, primary survey, secondary survey, obtain the investigations, check for the reflexes, manage the patients, secure the airway, ensure the breathing, ensure the circulation, if required perform BLS, if required perform ACLS, and manage the underlying cause, right? Right. So with this, I'll end your lecture. Thank you, all of you.